Welcome to the Site Management and Performance Conference Call. My name is John, and I'll be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct question-and-answer sessions. Please note that this conference is being recorded. I will now turn the call over to Ms. Tracy Williams. Ms. Williams, you may begin.
Well, good afternoon, CTN members and affiliates. Thank you again for joining us here at the CTN Web Seminar Series. Today we'll discuss site management and performance. Al Cohen, Dorothy Sandstrom, and Brigham have taken some of their expertise and put it into one place. So please feel free to ask all your questions at this time, because this is definitely a topic that folks were interested in when we polled our members and affiliates for topics for the Web Seminar Series. In terms of questions and answers, we have specific times when we'll open the lines for those to ask questions. Others who feel more shy and would like to use the Q&A feature on the dashboard, please do so. And also, we'll have different polls we'd like to hear from you, so please use the dashboard to make your selections, and we'll give you some options there, too. So I will start off by handing over the dais to Dr. Brigham.
Thank you, Tracy. And good morning or afternoon. I guess it's morning everywhere. Tracy, thank you so much for putting this together. For those of you, I know many of you presented these webinars in the past. I've been involved in one previously, so I'll state the obvious and say I'm not an expert on presenting in webinars, but Tracy is, and she's done a fantastic job of getting us organized and moving us along and getting us to this point. Yeah, so thank you, Tracy. We have several presenters, and I can say that I am interested in hearing what my colleagues have to say. Now, Al, I thought these presenters were in alphabetical order, but Al tells me they're actually in order of importance. From most important to descending, so I think he's probably on with that. But each of us are going to come from a slightly different perspective in terms of our role within either the node or the type of organization of our node, and we'll be getting into some detail with that. Go ahead and move me to the next slide, Tracy. Thank you. So our objectives are to review the strategies for improving site management and performance success. We all want to be a top-performing site. When we get in study, we want to be the site or have the site in our node. This is becoming increasingly important in these economic times when resources are increasingly scarce and cost-effectiveness is at a premium. And, of course, from a site perspective, in trials can have a large impact on future opportunities to participate in research. So there's a lot at stake in being successful as a site. So it's a very important topic, and having strategies is important. So we also want to understand the management of sites in what we've divided into 3 stages: pre-implementation, implementation, and closeout. The opportunities and challenges shift as a project progresses, so we want to emphasize some things that we think have been helpful and can be important for performance in each of those stages. And lastly, we want to consider factors that contribute to success performance. We'll talk a little bit at the end, but I'm sure we'll each work those factors in as we go throughout the presentation. So next slide. Site management strategies. I guess implicit in this is have a strategy. So when you look at these various phases, pre-implementation, implementation, and closeout, it can be easy to fall into, particularly if you're not leading the trial, and sites don't lead trials, so we're in somewhat of a follower mode with the lead investigator and maybe the RRTC in our node, feeding us the performance objectives and things that need to be done and the list of to-dos and so on. But we want to get beyond that and have our own strategy for success in each one of these stages, be proactive and anticipate the challenges at each stage. So, the kind of old idiom, success is no mistake, comes up. You really need to anticipate the important factors at each stage. Next slide. So here are the stages I mentioned before. In pre-site initiation, we'll go through that in some detail. I want to mention here, and I will mention, if I remember to, numerous times throughout this, that in the pre-site initiation, probably the most important factor is the recruitment of talent, getting the right staff and creating the right environment. So success really falls, 90% of it, in my view, falls on the research coordinators and the RAs. People don't come to enroll in studies at Maryhaven to see Brigham, and they don't tell others to come to the study because of their experience with Brigham. They do it because of their experience with the research coordinators and the RAs. So Kim Ross and Leanne Williams and others that are here, they're key. Having the right staff, bright people who are friendly and attractive to participants to be involved with. Implementation, of course, is all about running the study, and that's where we really get to measure our performance. And then closeout is, crossing the T's and dotting the I's, staying with it till everything that's important is finished off at a time when you can be shifting focus to other things. Next slide. Well, I like to think of this thing fitting together as like a chain, where the chain is only as strong as the weakest link. So we look at timely startup. So, how quick can we get the site started after the investigator meeting? Because the burning of resources is at full speed pretty much once that investigator meeting happens. It costs just about as much to have a site with all its staff on board not seeing subjects as it does to have one that is actively enrolling and treating. So that's a critical time. And for the trial to be successful, that time needs to be as short as possible. Of course, subject recruitment. We can't study anything without the subjects, but once we get them in the trial, then we need them to actually get the treatment that we're studying, so exposure becomes critical. Availability of primary outcome. That's what we really want to know to answer the question. So sometimes we're gathering that during the treatment phase, and we can have good primary outcome without good follow-up retention, but both are important. And of course, data accuracy and integrity, the audit results, and just how good our data is, and how well we're doing at maintaining it, because without all of these things, we really end up with a compromised product or nothing of great value. So that's how I see them fit together. So and how these things happen can vary greatly depending on the experience of the site. So in our conversations leading up to this, we thought it would be interesting to find out who's on the call and how many trials they've been involved in, because a site starting up and doing its first trial is going to be very different than a site that is running trials continuously or has run many of them. So, Tracy, I'll turn it over to you for the poll.
So we'd like to hear from you all. The first poll question is, how many CTN trials has your site participated in? And let's look at the progress here. Since we have folks who have more experience on in working with the research trial, so that's great. That tells us a little bit something about the group. And then we'll go to the second poll question. Choose the types of CTN trials your site has participated on or is currently participating in. And we have some variability between behavioral trials versus both combination of medication-assisted and behavioral trials, but mostly both types of trials. Great. So thank you, everyone. We'll go back to the presentation.
Just comment for Al's benefit, because I'm not sure he was able to see the polls, and he's got the next slide. But Al, it looked like the majority of the people on the call have had the highest number, 5 or more clinical trials, and the majority of them have done both behavioral and medical trials.
Great, thank you, thank you. It sounds like we have a very experienced group on the call today, so I'll be looking forward, and we'll all be looking forward to hearing some of your experiences. I want to talk a little bit about the first phase, I guess we can think of it as, of moving into a clinical trial. Since we've all done these in the past, we all know that these studies, these trials, are very complicated animals. They're not simple, they're complex, they're demanding. And so it's very, very critical, because of the demands that will be put on the sites, the staff, all levels, that we attempt to get buy-in from the organization moving into a new clinical trial. That is, support from ownership, management of the organization, the larger structure, and as I think it is very important, support from staff that will and will not be participating in the trial directly. Some things that help, because these research studies are very, very different in most cases than treatment as usual. And so buy-in oftentimes can be facilitated by maximizing transparency of the trial, maximizing transparency of what these research folks are doing. That in a lot of cases, it's certainly at BART, is very much different than treatment as usual in the day-to-day operations of the local sites. So, making sure that everybody in the organization, from the top down to the frontline staff, understand the importance of why research is being done in their site, why we need to do clinical research. Remember, not everybody has had a very pleasant experience or very good memories of clinical research. So buy-in is accomplished by understanding and disseminating information. Make it very, very clear that the CTPs benefit in many ways from participating in these types of protocols, these types of research trials. They benefit clinically because the research studies often bring cutting-edge, frontline, evidence-based treatments to sites that heretofore may not have had that. Of course, there's the financial benefit. I don't think any of you or any of us who have been doing clinical trials for a long time are still under the delusion we're going to get rich by doing this. But the financial support helps to support staff, helps to buy some equipment, helps to afford treatment to a group of people, patients who may not otherwise be able to enter the doors and get treatment any other way than through the research portal. And finally, I think it's always important to emphasize that there's great competition for the opportunity to participate in research trials, and if your site gets selected, it's oftentimes an honor. It's oftentimes comes with a great deal of respect, and it's a feather in everybody's cap. So that is certainly one of the considerations in your pre-site initiation thinking. Now, if I can get to these next slides. Well, next slide, please. Bear with me 1 second. Okay, I'm gonna do the best I can here. So, continuing with pre-site initiation issues, concerns. It's very important to identify key organizational stakeholders. Most of you and most of us know who those folks are, but in some cases that these stakeholders may change depending on the nature of the trial, who's going to be involved, and so I can't emphasize enough how important it is to identify and engage the organizational stakeholders. At BART, a lot of these stakeholders are very, very accessible to us. They're the ownership of the company, they're senior management, they're clinic directors, program directors, and so those are the ones that we start with when I start with when I'm trying to bring a new study into the organization. There's the clinical staff. Again, those people you work with every day, as well as physicians, nurses, counselors, frontline staff. All are very, very important, and these are things that you can't start on too soon in the implementation or in the pre-site initiation phase. When you're just getting ready and just getting started, laying the groundwork can save you and save all of us a lot of headaches, a lot of grief later on. I'll be talking a little bit more about that when we move into our discussion about our various sites. Getting sites up and running on time. Well, NIDA would like to see that happen, and we all try very, very hard to be efficacious in the way we implement these studies. But some of us are a little better at this than others in terms of thinking ahead and coming up with ways to help facilitate and reduce redundancy, reduce lag time. And one of those people is Dr. Teresa Winhusen, the PI at the Ohio Valley node. Teresa is well known to us all, and Teresa has led many, many studies, and she has developed a tool that, as you can see, is available on the DSC's website in the Investigator Toolbox, and Tracy is giving you the link right there. Greg will talk a little bit more in a second about this tool, but essentially what Teresa has done is created a tool that we can use that helps to minimize the time between the national training and enrollment of the first participant at sites. Now think about that for a minute. You have all this setup time going in, pre-initiation, hiring of staff, putting equipment in place, getting everything ready, and then there's usually an investigator meeting of some sort where training takes place. The time between hiring staff and putting patients into the study or randomizing first patients used to be very, very long, and consequently it was adding to the cost of studies. The time between the investigator meeting and randomization of patients is now much more streamlined and much more efficient, and therefore much less costly, and people get into the study much quicker. So Greg will tell you a little bit more about that tool, and again, it doesn't hurt to have plans, and training plans, retraining plans, which we'll talk about a little bit more, are always very, very useful. So please remember Teresa's tool, and I'm going to hand this back off to Greg. Tracy, next slide, please.
Hey, thanks, Al. You did a really pretty nice job of introducing that, so I don't have a lot more to say about it, except I'll agree with Al that, Teresa has a certain genius for, managing these very complex projects and making the trains run on time. And part of that comes from the tools that have been developed by her and her colleagues to stay on top of these things. So this is an image of the pre-initiation checklist that's available in the investigator's toolbox. And, once you've populated your target dates, as you actually start to complete things, you can revise this, and based on the timelines you develop, then it tells you how far off you are from being able to start your trial, to actually see subjects or other key time points that you want to use. So it's a very nice way to sort of inventory everything that needs to be done before certain milestones are achieved. Of course, one of the things with this pre-initiation is that many of these things are under our control, and then many of them really are not. Often we can't control how an IRB will react to an informed consent or a protocol change, or how often they will meet, or what will happen along the way. So we can have our best laid plans, and then unexpected things come along. So a great advantage of this tool is that it allows you to almost immediately evaluate the impact of unexpected events or untimely events on your kind of bottom line for getting going. So it's a very nice tool. We hope people will use it and find it helpful. And now I'll turn it over to Dorothy, and you can advance to the next slide.
Hi, everybody. I'm going to be talking a little bit about the pre-site initiation and implementation of the protocols. The biggest issues that we have are recruiting, training, and then motivating a research team. And this ties in with the lag between our national training and actually enrolling our first participant in the study. When there's a longer time frame between that, it's hard to keep the research team busy. You've had to hire them and get them on board because they need to do the national training, but then if there's this big lag between the end of the national training and when they actually begin enrolling participants, you really need to keep them motivated during that time frame. When we participate in the national training, there's a couple of things that have to happen for every one of these. First is the preparation. For many of you, you know that there's always some major pre-implementation training webinars that need to occur before you go to the national training, and some of them are very lengthy and very time-consuming, and you need to make sure that everybody completes the training, that all of the forms that are necessary to ensure that they have completed it and validate that are then sent to the necessary people so that they know that your site has trained all of their staff in the pre-implementation training, and that they're ready then to move on to the national training. Participation in the national training is very, very important. We learn the logistics of the protocol at that, and it's very, very important that anybody who's involved in the study attend the training so that they can see the importance of the research, how they're supposed to be doing things, how the data is supposed to be collected, all of the necessary items for a successful trial. Now, one of the things that we have found in the trials that we've participated in is that if we have a CTP that it requires a subcontract for the study, that they're not going to get money at their site probably in time for them to have monies to pay for their site staff to travel to the national training. And what we routinely do here in Pittsburgh is that I will put that money in the RRTC budget so that we can pay for everybody to go to the national training and not have to worry about getting funds to the CTP site in a timely manner so that they have funds on board in order to send their staff to the training. And that has worked out quite well for us. And that's one last thing that we have to worry about then is the logistics of funding people. We just do it for them and it's done. Then the last thing in the national training is following up. If there is a lag between the national training and the actual enrollment of study participants, you need to follow up with the sites and make sure that everybody is practicing. If they're doing CBT or some kind of therapy, that the staff continue to practice with each other. do the necessary things that they need to do, that the RAs are practicing the assessment procedures so that everybody keeps up their skills and that they're ready for when it's time to actually begin enrolling their first participant. Could I have the next slide, please? Okay, part of the pre-site initiation is planning the local implementation. This involves the participant recruitment and retention planning. How are you going to recruit your study participants? That will certainly be based on the eligibility criteria of the study. If it entails a study where the people have to be in treatment at your site, then that's different than if you're going to be just recruiting people from the local communities to participate in your study. And how you go about that recruitment is going to vary depending on the protocol. And then there has to be some planning about how you plan to keep these people engaged and retain them in the study so that they return for their follow-up visits. Another important thing is networking in the community. An example of this is for our 0049 protocol. It was very important for sites to network with their HIV clinics to get connected with HIV-related service agencies so that you could try to track all of the participants for their follow-up visits. And so that there was a lot of networking in this protocol to get the study staff known to people out in the community, shadowing the HIV clinic staff to see what it is that happens at an HIV clinic so you have a better understanding of what kind of services are being provided to your participant, those kinds of things. The other aspect is organizing and implementing and monitoring the pre-initiation tasks. If you have, how you go about this is going to depend on whether or not your site is research naive or if they're people or a site who has participated in many clinical trials. If they have a lot of experience, then this task is less of a difficulty than it is if you have a research naive site. And I'll talk a little bit about that more later on. The last thing in the pre-site initiation is the local SOPs for the study implementation. It's gotten much easier in the CTN. We now have these SOP templates that are very, very useful for the study sites and make it much more easier for them to generate their local SOPs. But it's very, very important for the local SOP to be completed because it's what your site is going to do specifically as it relates to each item in your study implementation. And I think that it's particularly important because it's how you're going to do your day-to-day operations. So if somebody gets sick and there's no SOP for somebody to pick up, then nobody's quite sure what they're supposed to do. So the SOP actually provides guidance to the site. And I think that at least here in our node, if we do everything within our power to help the sites come up with their SOPs and to help them tweak things when they run into difficulties about how they should say they're going to be doing a study procedure. So these are very, very important for a successful trial, is that you have local SOPs that make sense and that will function for the particular site. Could I have the next slide, please? Okay, starting the study. The biggest part of starting the study is going to be your recruitment of your study participants. Internal referral, you want to meet with site clinicians. Let them know what's going on with the studies, what the eligibility criteria are for the studies so that they can then have in their mind's eye what it is that you're looking for so that they can refer potential participants to the research staff. Oftentimes we've done, we call them placemats, where we put the study information on a laminated card or piece of paper, depending on the size of the study. So it's readily available for clinical staff so they can see what the study is, what we're looking for, and it makes it easier for them so they don't have to try to remember all the details. Once you start the study, utilizing performance feedback is very important because you can make adjustments then to whatever the recruitment procedures are, or maybe retention, or if there's treatment exposure issues. If you keep tabs on the performance of the site, are they meeting their recruitment goals? Are they behind in study recruitment? If they are, what are you going to do to help facilitate their increasing their study recruitment? If there's issues, for example, with treatment exposure, what are the problems? Is it the urine drug screen that there's an issue with? You have to kind of determine what the problem is, strategize then, and try to find a resolution and provide feedback so that whatever the problem is can get resolved in a quick manner. The other important thing once you start the study is early quality monitoring and improvement. It's really important to do a local visit, very monitoring visit early on and prior to the national EMIS visit so that you can work with the staff at the study site, identify what, if any, quality assurance issues there are, in making sure that they're doing the data entry correctly, that everything matches the way it's supposed to, and those are things, if you start early, you can train them basically on the go in what's supposed to be happening so that they are then prepared. They know what their tendency of errors tends to be, what they need to look for so that by the time the national monitors show up for their first visit, hopefully their data entry and the quality of their data is up to par and you don't have very many errors on your monitoring report. And that is the end of that. And Tracy now has some poll questions for you.
Well, this will be our third poll, so let's go off to that and get ready to use your dashboards, folks. Poll question is, what ways have you found most successful to recruit participants? And we're showing the results as you guys are putting it in. So we have some flexing going between advertising in the newspaper and using flyers versus other options. Now, interestingly, we have other options there. Do we have any brave souls who'd like to give any feedback to us on some other options that you found most successful? Operator, can we open the lines for those to talk about their other options?
Tracy, can I also mention that there's a typo in C that should be radio advertising?
Yeah, it is. It says ratio advertising. Unfortunately, that was my little typo. Sorry about that.
Okay, nobody's perfect.
All right, thank you. But that's radio advertising. So, operator, can we open the lines for those to give feedback who use other options?
Thank you. We will now begin the first question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using the speakerphone, you may need to pick up the handset first before pressing the numbers. If you wish to ask a question on the web portion, you can ask using the Q&A tab on the top of your screen. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Standing by.
We'd really like to hear what those other options are. Okay. Well, we have a shy group here. Okay. Al, for your purposes, mainly we have about 44% of folks who advertise in a newspaper and find that to be most successful.
Yeah, yes, I'm among that group.
Okay, great. All right, we'll go back to the presentation then.
Hey, thank you, Tracy.
No problem.
So I think those other options may be the secret ingredients of success.
Yeah.
People are holding those back right now. So, but I wanted to comment on that. I would say historically, I would agree for my own site, for Maryhaven, that advertising in the newspaper has been the strongest option for us. But a couple of things have happened. So historically, that's been the case. First time we advertised was for CTN 15, which was the Women and Trauma Study. And we ran our first ad. We had 300 calls. We ran it on a Sunday, had 300 calls by like Tuesday or Wednesday of the following week. And that advertising remained fairly robust over the course of that trial. It continued to be productive, although the response dropped off rapidly. And that has been typically the case with us for really any particular media outlet, but newspaper in particular. We get our biggest response right away, and then it fades. And so we've found that a strategy that might work for us right in the beginning to get ourselves going is advertising in the newspaper, but over time, maybe flyers or networking in the community or other ways work out. Also, we've heard from other sites things that work for them. So the first one on that poll question, for example, was billboards. And I love that idea, and I've heard sites have a great deal of success with it. And in a recent trial, we bought a package of billboards. It turns out they're actually fairly economical in our area to purchase. We even purchased one directly across the street from our own site so that patients who come here, community participants who come here, who might not hear about our trials would see it on a billboard. And we thought it was a great idea, so we had 8 of them, and I think we ended up getting 1 participant from that. So there were other advantages to it. We liked seeing them up. It was enjoyable. It was fun, but it really wasn't productive for us, at least in that particular trial. We've had other trials where radio was really kind of the top way of getting them, but again, we had to rotate through radio stations. So I'm sure for many of you as well, you have to have more than one outlet, and you may find that differs throughout the course of the project, but also from project to project. So,
well, hey, Greg, this is. Let me just add one other thought, and that is, I don't know how many of you live in areas or do your research in areas where you have multiple newspapers that you can choose from. Where we do a lot of our research in San Francisco, there are several daily publications and weekly publications that we could advertise in. It turns out that through a process of, I guess, some common sense, talking to people, and trial and error, that when we've advertised in what's called the free papers, or there's something called an LA Weekly or a San Francisco Weekly, as opposed to the San Francisco Chronicle or the New York Times. We've had great success in those newspapers that we believe are more frequently read by our patients, as opposed to maybe the principal newspaper for the local area. So that's just something else to consider, which kind of paper to advertise in.
Yeah, Al, this is Dorothy. We have a similar free paper called the City Paper that we have a great deal of success with here in Pittsburgh. It is in all the bars and restaurants. People, if they're waiting in line to get seated, can read this newspaper, and it has things that are happening in Pittsburgh and interesting articles, and it's free. They just pick it up and read it. We've tried both the newspaper and radio, and we even did a TV ad. None of those were very successful, and what we find most successful here, interestingly, is bus ads. We have a large transit system, and we put these bus ads up, and they're very inexpensive, and you buy them by the month, and the billboards go up in however many buses you want to pay for. But if no other person buys an ad for the bus at the end of the month, then your ad stays up, which is very convenient. And so you don't have to, it's very cost efficient to use the bus ads here.
Good points, Allan and Dorothy. Yeah, actually, Dorothy, that was our preference. We wanted to do bus ads, and we learned that they stopped doing them in our area.
Oh, that's a bummer.
I know. That's how we ended up with billboards, but we'd heard you'd had great success with those.
Yeah, and
so
billboards,
I guess it's knowing your region and what works for your project and your community.
yeah, and I think you only find that out as you do studies, what works and what doesn't work. It's all trial and error, and then when you finally hit upon something that works, we just kind of stick with that because we know that it is going to work. And billboards here are very costly.
Yeah, so those are good points. I mean, when we do media advertising, part of our strategy is if we don't get a really robust response almost right away, we assume it's not going to really pan out for us. And while we may not abandon it, we'll continue to use it until we're sure it's not going to pay off. We immediately go into problem-solving mode and looking for other ways to recruit people. So if we're using something that's really worked for us in the past, but it's not working right away the way we expected, we try to anticipate that and go into, like I said, problem-solving mode.
Okay. So we would like to hear from our participants. If there are any questions at this time, we'll going to go into our next session where each of the presenters will talk about their various sites and some of the unique qualities about them and some of the things that are working well for them. So, operator, if we could open the lines quickly.
As a reminder, if you have a question, please press star, then 1 on your touch-tone phone. And if you wish to ask a question on the web portion, you can ask using the Q&A tab on the top of your screen. Standing by for questions.
Okay, I think we can continue. How about you, Greg? Why don't we take the Maryhaven site?
All right, thank you. So, yes, as Tracy mentioned, we're each going to talk a little bit about the organization of our site or node as it relates to individual site, where it kind of fits in with the RRTC and Division of Labor and Responsibility. So I had a note here to myself to comment that, you know, it helps to start with choosing good parents or choosing a good node. And I like to make this comment every once in a while in the CTP caucus meeting where all my CTP colleagues are. And as soon as somebody makes a comment about how great their node is, it sort of brings out this be true to your school spirit, and everybody starts talking about what wonderful node they have and what a great relationship. And so it's always fun. I think the CTN is a lot like Lake Wobegon in that way, that all the nodes are above average. So I like to think of mine that way. And I know, these webinars are so much fun. I can just, my computer screen is just cracking up right now listening to this. So I'll choose to think that, you guys are doing that too, as opposed to the eye rolls. Next slide. All right, so this is our layout. I borrowed this slide and modified. I borrowed it from Dorothy, so thank you, Dorothy. And this is set up. So we have the node, and within the node is the Regional Research and Training Center, which for us is at the University of Cincinnati, and Teresa Winhusen is our PI for our node. And then Maryhaven, in this case, is the CTP, the Community Treatment Program. We're located in Columbus. It's about an hour-and-a-half drive. So most of our communication is via email or teleconference. In fact, one of the things I really look forward to about investigator meetings or steering committee meetings is to get, a chance to sort of spend extended time around my colleagues at University of Cincinnati. But even without that, or as that is spaced out, it's impressed me quite a bit the amount of relationship and the efficiency of working together you can achieve through email and conference calls. Of course, we do have on-site visits, particularly for startup and then ongoing quality assurance monitoring visits. So next slide. And our kind of way of setting things up is that the CTP employs the site PI. At my site, that's me. And then we also employ the research coordinator, the research assistant, the nurses and physicians who work on the trial and see subjects. They all work for the CTP, work for Maryhaven. And here we have Monique Lumpkin and Leanne Williams, and we have Dr. Lotus and Dr. Sarita Salzberg and Shannon Ross, Tiffany McFadden, and a number of people, other people that have worked on our trials over the year. Kim Ross, I think I'm failed to mention her. These are all RAs and physicians and staff that work on the studies and see the subjects and work for Maryhaven as employees. Then the University of Cincinnati, the Regional Research and Training Center, provides the protocol managers or protocol specialists for both trials that they lead, but also for trials that are led by other nodes. They provide quality assurance monitoring, training specific to the general training for the trial, human subjects training, good research practices, the use of numerous assessments that are a part of, regular part of the CTN. And then they provide regulatory specialists and expertise, so they prepare the IRB submissions and reports and responding to the IRB. So it's a good division of labor, and it provides for all of the important things to be covered, but it does require a good communication plan. Next slide. So, in terms of the tasks that kind of get done by these folks working for the two different organizations is, on the local level, we're responsible for recruitment of subjects. We provide, of course, the treatment as usual, as often as a platform or as even a condition in the study, as well as the study treatments. We're responsible for fidelity to those treatments locally, if it's monitored locally, or responding to the national fidelity monitoring. We handle the data on site, of course, maintaining source documents and doing data entry. And we communicate daily or very frequently, at least, with our node colleagues who provide weekly site supervision. So we have calls with our protocol specialists called local calls, whether our node is leading the trial or not. We still have these weekly calls that are just for our site on each protocol. And that's a sort of micro-level monitoring of what's happening with each individual subject, from screening, pre-screening to screening to participation in the trial and follow-up. We go through each person each week and monitor how that's going, any problems that are coming up, and how to address any challenges. So there's a very frequent and in-depth involvement of the RRTC in what's happening with each subject at our site. They also provide ongoing training and problem solving, so if we have turnover in staff or if issues come up where additional training is needed, they provide that. They're very, very experienced, as I guess all of the RRTCs are, at running clinical trials, so they have a wealth of experience and information about how to solve problems when they do come up, which might be novel for us. They track individual subject progress in the way that I've already mentioned. So in terms of performance on each of these things, going back up to what the CTP provides, we utilize liberally the trial performance reports, and we try to create an environment where, we want to see green lights, of course, on everything. And we're watching those all of the time. We're comparing our performance to those benchmarks that have been set up to, make those indicators either red, yellow, or green. And we also like to compare ourselves with other sites within the trial. So we create sort of an environment of, I think, a good-natured competition. So both with the benchmarks and with other sites. And we talk about this in our own local staff meetings weekly. So we have a time each week where all of the study staff meet here just locally, just the Maryhaven folks, and we talk about how we're doing. We tape up our progress and, our thermometer on how we're doing towards our goals on the refrigerator that's right in our meeting area. And we have a good time with that, talking about how we're doing and watching the progress of other sites. And of course, it's a team effort. We want every site to succeed in the clinical trial, and without that team approach, the trial cannot be successful. But we also like to have, some local pride and try to do our very best here. So when the research subject walks into our research area here at Maryhaven, you can kind of see the staff sort of light up. I think of the this may date me somewhat, but I think of the TV show Cheers, where you want to go where everyone knows your name, and, they're always glad to see you. And certainly we have that atmosphere here. So when a research participant walks in, of course they may be getting, a gift card for compensation for their time and trouble and travel expense and all that, or even contingency management if it's part of the protocol. But they're also getting the reward of just knowing that people care about them and are genuinely happy to see them. And, of course, we have that because we do have empathy for the participants and we get to know them and care about what happens to them, but also because we are completely dependent on their behavior to be successful in our trial. So we need them to be involved, to refer other people they know to the trial, to be faithful to the treatment, to stay with us through all of the assessments and follow-ups, and to provide us good data, to feel comfortable with us, that they can tell us the truth, and even if they've had a difficult time, that it's it's okay to say that here. There's no consequences, no additional consequences in our environment for people that are having difficulties. So all of that's critical. That's sort of the local environment we try to develop, and I think do develop, which comes back to my original comment that the success is 90% or more about the staff and them working together. So I know we all cross-train within our site so that multiple RAs can do these things, and if somebody's missing for vacation or otherwise, someone can fill in. But we also, so there's cross-training and having the qualification to do that, but then there's also having the spirit of the thing. And that's what I love to see, is when you really have the spirit of people being able to do multiple things, so that when a participant walks in, it's not just who's assigned to that project to do that chore, but who's available and can do it, and getting to the person right away, and having a pride in that high quality of excellence and service to participants. And so they catch that their time, we know their time is important, and they respond to that as well. So I think that's the highlights of what I'd like to say about my site. And so I think I'll turn it over to Dorothy to now talk about her node and the way they do it there.
Hi, everybody. Could I have the next slide, please? Here, what I've done here is to kind of put in what the structure of the Appalachian Tri-State node is. We have the node RRTC. We have a local site, which is our main site, Addiction Medicine Services, and it's actually, why we're a little bit unique is that our main CTP is actually housed on the same floor as the RRTC is, so that we're kind of like all right here, which makes it very convenient for recruitment and meetings and everything else. We have another local site that's currently doing the 49 protocol, and we have a remote site in West Virginia at Morgantown at West Virginia University that is completing the 47 protocol. And we have 3 additional primary CTPs, one located in Youngstown, there's another one in Pittsburgh, and there's one in Greensburg. And then we have a group of ancillary sites in the event that we need somebody for a particular protocol. And our Addiction Medicine Services site is a very large service line. We have adult and adolescent treatment programs. We have a perinatal addiction program. We have a methadone treatment program, a highway safety program, an ambulatory detox program, 2 inpatient units, and 1 inpatient detox unit. So we provide a great deal and variety of services for just about anything anybody would need. And again, the primary adult and adolescent and perinatal addiction program is right here in our building on the same floor with the RRTC. Could I have the next slide, please? The structure here is a little bit different, I think, because of the fact that the RRTC and the main primary CTP site are housed in the same place. We handle the research staff hiring at the RRTC at the local site. We provide them with their training and support for the staff that we hire. And then for our remote sites, for example, West Virginia University, they hire their own staff, and we just assist them in training and supervision and quality assurance, all of those issues from the RRTC. We have a central research team that has worked with us since we began in the CTN. It's a core research team. We have had 2 people leave over all of these years, and both of them returned to school. So the benefit of that is that I have this great team of research staff that encompasses our study coordinators, our RAs, and our therapists who are always assigned to a protocol. So a certain group will work on one protocol. When that protocol is done, we'll move them to another protocol. And so for now, that has worked out well in us being able to finish a trial, reassign that group of people to another trial, and to keep everybody here. And it's really important and that we've had the luxury of being able to do that because, as you all know, we spend a great deal of time and money in training research staff. And every time somebody leaves, you have to retrain somebody. It becomes expensive and time-consuming, and we've been very, very fortunate to have a research staff that we've been able to retain since we started in the CTN. And again, just having all of us in the same location is certainly conducive to a cohesive team and for oversight. It makes it very easy. We have weekly meetings with each of the different protocol teams. We can troubleshoot on the spot. It becomes logistically very simple. And again, we do the training function at the RRTC. Could I have the next slide, please? One of the things that we thought was important to talk about was planning and funding, because the funding is becoming increasingly problematic with less monies available now with the sequester that has been going on. So it's very important to be able to plan your funding and to try to make sure that you have what you need in order to undertake a trial. Here at our node, we do all the budgets for the trial. So, for example, at West Virginia, they'll let me know what all their staff is going to cost. We'll put the budget together for them, and they process it through their university. That way we've got some oversight on whether or not the costs are in line, whether or not they have the appropriate staffing that we think that they're going to need to do the trial. If they say, oh, we need 1 RA, we may go back to them and say, oh, you might be better off with 1.5 RAs. And so we can help them with that way. We also coordinate all of the subcontracting and, of course, the CCTN funding. It comes in through the University of Pittsburgh to us, and then we subcontract with off-sites out of Pittsburgh, sites within our own university. We have something called a sub-account, which makes it easier to fund them because you don't have the paperwork of a subcontract. Some of the challenges in the funding that we have seen is coordinating the financing prior to issuance of CCTN funding and supplemental allocations. And all of you are familiar with this. You know, we've got a protocol that we need to start. We have to hire people at a CTP site, and there is no money because we have to put in our administrative supplement. Then the supplement award has to come. Then you have to initiate a subcontract to process through your major university to the CTP site and get it executed before you can begin. So there's a lot of planning that you need to do because oftentimes the RRTC is going to have to front money, so to speak, to the CTP so that they can get like startup funds so they can begin the study prior to getting any administrative supplemental funding from NIDA. And so it's important that you structure the timelines accurately, that you start hiring people when it's the most reasonable time to hire them. In the past, there have been studies that, you know, we've had to hire the people, and then for 4 months after the national training, they're still waiting for enrollment to happen. And so that's becoming more streamlined now because everybody's seeing that that doesn't work quite so well, and it's important to with the new structure and the new tool that Teresa has come up with, the plan is to try to get sites to begin enrollment within 30 days after the completion of the national training. And it's a doable thing, and I think that we have to move to that because it saves a significant amount of money. When you have 75% or more of your budget allocated for personnel, having people sitting around for 2 or 3 months after they've gone to the training with little or nothing to do becomes problematic fiscally. And again, you have to have some kind of planning in the event of something like the sequester, where budgets have been cut, and how you're going to manage the budget cuts that are going to happen to each of the sites. The other thing that's important is invoicing from your CTPs. It can be problematic. We try to stay on top of it here. And I push them. If I haven't gotten an invoice, I go, where is it, where is it, where is it? Because without those invoices, we can't process the subcontract monies to them. And in the end, you're fighting to get their last invoice from them within the time that you need to submit all of your FSR paperwork to NIH. And so we have really set a system in place here where the invoices come on a regular basis. I rarely have to track one down, but we stay on top of it so that we don't, in the end, end up with a great deal of outstanding invoices that we haven't received that we're trying to track down so that we can close out the current project year. Next slide, please. The next is related to site management. As the node, we have to monitor the progress per the timeline that's set up by the protocol, and then problem solve if issues happen in the trial. And so we live by the trial progress report, as everybody does, and we watch all the time what every study is doing, what is happening, and monitor the progress. And again, we keep on top of each of the studies to find out where we are with recruitment, what issues are we having, are there any problems with retention, are we getting our treatment exposure, what are the problems, and troubleshoot as they come along. Our QA monitoring we see as a resource here because our QA monitor can go in, do a local site monitoring visit and troubleshoot and try to deal with any issues prior to a national monitoring visit so that when we have a national visit, we have all of our ducks in a row. Now, some of the challenges is coordinating teams. You have to build effective skills mix, show appreciation for the team efforts. We're like Maryhaven, we cross-train everybody. So anybody who's working on a protocol is cross-trained so that everybody knows everybody else's job. So if somebody has to take off, if somebody gets sick, if somebody needs to go on vacation, there's a backup person who can serve that role, and that works out well. The other important thing is with a remote site, it's really important to emphasize to them that they need to hire staff that have adequate experience with research because it will facilitate a good trial versus having people who've never done research before. It makes it very complicated. And if you have people who have adequate experience, then they can really avail themselves of the resources that are provided from the node. With training and retraining, our RTC provides all of the training and retraining to all of our sites, and what we have found is, again, research-naive sites and staff are going to need much more support from our RTC, and the training is usually more extensive, but because you have people who are just not used to doing research. Next slide, please. The challenges, again, implementing protocols and guidance during the protocol. Our RTC is responsible for the IRB submissions for our local sites. We work and coordinate with non-local sites. So for a site here, because the money is coming into the University of Pittsburgh, it has to go through our University of Pittsburgh IRB. So we do all of the submissions for the local sites here through our IRB. If it is an off-site, for example, West Virginia, we help them with their IRB submission, the consent form processing, all of that. They have to submit it to their IRB. Their IRB is the IRB of record, but then we have to submit it here for a secondary review and approval because the funding is coming through the University of Pittsburgh. So there's a lot of coordinating with a non-local site in order to handle this regulatory paperwork that needs to be done. And we really help them navigate through the implementation process. We help them with their SOPs. If we have a site who's never done an SOP before, we, of course, have to spend much more time working with them and then helping them in implementing the study procedures than a research site that has done multiple trials. We do have regular QA monitoring, site visits for support, so that there's a schedule that's set up with our local monitor. She'll go down. Even here, there are regular schedules in which she visits and does her sites. She will try to identify and resolve any QA issues as they come up. We hold weekly meetings and weekly calls for our off-site. And we pretty much do that through the active phase of the trial. At the early phases of the trial, the pre-implementation, once enrollment starts, we actually physically will go to an off-site for a day, see how everything's going, provide support, what do you need, what can we help you with, and just to offer them as much support as we possibly can until they kind of get the swing of things and a schedule is set and the procedures are moving smoothly at the site. And at that point, then, we just start doing weekly calls with them through the active phase. And then once we usually get to data lock, we discontinue the calls unless they have problems. The next slide, please. Participant recruitment, retention, and treatment exposure. We all know these are the big things. These are a trial progress report. These are what make and break a trial. Again, as we've discussed, and Greg has talked about, fostering buy-in from the clinical staff. That's really, really important because they can help identify study participants, and it's really important to nurture those relationships here. So we will work with our clinical staff. As I said before, we give them information about each of the trials, and then they will identify study participants who may meet eligibility for a trial. So you've got to be able to have that ongoing working relationship with the clinical staff in order to get the referrals that you need for a trial. Building strong rapport with the study participants. Greg has talked about this. This is really, really, really important. Our participants, I have such great study teams. Our participants love to come here, and they love to come back in for their follow-ups. We treat them with dignity and respect, but we also set boundaries for them. And they actually enjoy coming here, and they enjoy meeting with the study staff. And so we really have always routinely had good recruitment and retention. When we did our 32 protocol, we had 120 participants that were randomized. Our 1-month follow-up, we had 100% follow-up rate, and at the 6-month follow-up visit, we had 99.2%. We lost one participant that we could not get back in. And I think that speaks to the skills and the personalities of our research staff. They do really good jobs, and they're really good at what they do, and that's why it is so important to be able to hire good staff who can make these trials a success. One of the other things that we've done just to keep up a good rapport with our study participants, we will routinely have sponsor some kind of a lunch. When we finish our 31 protocol, we had an appreciation lunch for our study participants. And there was a plaque that had been generated, and we hung that up in our waiting room. And people like that. It makes them feel good. It makes them feel that what they've done and their little participation in this research project really is important and it has some meaning. We also do the same thing with our clinical staff. We do a staff appreciation and we'll sponsor a lunch for them just to thank them for all their help in our recruiting study subjects. Next slide. Let's see, just to summarize, we have the centralized oversight. Hiring and staff retention, again, is really, really important. I'm fortunate that we have the same research staff since we first started. We have centralized training, and we have the clinical staff, participant relationship building that we have, and we have a really, really good working relationship with our clinical staff here. And I think that's from my end, and I'll turn it over to Al now.
Al,
Hi, thank you.
Al, this is Greg.
Yes.
I'm going to make a terribly unfair comment, but I just want to remind you that we have about 15 minutes left on the call.
Thank you.
Okay. Sorry, Al.
Oh, that's fine. Well, for those of you who have hung in there with us this long, I want to, we're here to talk a little bit about site performance, helping to ensure success in these clinical trials that we're all involved in. And I want to give you a little bit insight from the CTP perspective, because Bart is clearly a CTP within the CTN, has been for well over a decade now. I'm the director of research for the organization. We have out here, we're all out in California. We're part of the Pacific node. Walter Ling's the PI of the node, and many of you know Walter. It's hard not to know Walter. We have a very small node compared to a lot of you. We have by small I mean we have a core group of about 7 CTPs that have been around for most of the time, a really inner core group of 4 or 5 CTPs that have been around since the beginning, as I have and as many of you have. We have a very close relationship with our RRTC. And because we're spread out all over the place, it's very, very important to nurture that relationship. I myself go over to our RRTC down at UCLA about once a week because when you do these, as the CTN has out, as we've added CTPs, as we've moved, as we've grown and morphed and changed, sometimes I think the communication between the CTPs and the RRTC can get a little stressed. And so we're working very hard to maintain our close relationship with UCLA, with our RRTC. Some of you know Bart. It's started out as an OTP system. It's still largely an OTP system, but we've grown. We offer not only the OTP and agonist replacement therapies, but we also are very active in providing integrated services. We do a lot of primary care for communities, mental health services, and, of course, our research component. The RRTC, our node coordinator is Al Hassan. Some of you know Al. Al and I go way back, and our RRTC takes care of pretty much the regulatory management for our studies, IRB submissions. This may be a model similar to yours, and providing QA monitors for our CTP sites. Our local sites, our CTP site, our BART site, hires its own staff. We do all of the training locally with the CTN and the lead node, and we do the monitoring our performance monitoring, engagement, recruitment, and retention, all more or less locally. One of the things I wanted to mention to you is this: to ensure successful trials, I think means that we have to have a very cohesive research team, research staff that is integrated as completely as possible with the larger staff in the CTP. All of you may know and have similar situations to what we do. I run a lot of the research for the CTN research for BART up in San Francisco at one of our large sites up in San Francisco. Now, we've done it in other clinics, but in San Francisco, that's a very, very, very busy place. They have 900 methadone patients and 100 buprenorphine patients and pregnant patient treatment programs and mental health services and a variety of primary care. And here we're trying to integrate a very complicated clinical trial. And I learned early on that it's very, very important not to have a we and a them kind of attitude. And we work very hard to have transparency, to have the overall staff, everybody work together as much as possible. The research staff reports to the rest of the staff about what the status of studies is. I think it keeps everybody kind of engaged, and I think engagement is the word. Next slide, Tracy. Let's see. Well, like some of you, BART has been involved in a number of studies, both medication and I lost the slide I was on. Where am I? Oh, here. And behavioral trials. We're just completing the 48 curb trial. We've just wrapped up BART's participation in the START follow-up trial, which was a buprenorphine methadone trial. The experience has been invaluable for us. One of the things I wanted to mention, you've heard some of this from my co-presenters today, and that is staffing and what it means to hire staff to do these research projects, and what it means for the CTP, for us, for you, when you're going 1,000 miles an hour on a research study and suddenly you lose a key staff member. For those of you who are lucky enough to be in Dorothy's shoes, and I envy that to some degree, to have staff that have been around for a decade is invaluable. What it also requires, and we've run into this, and maybe you have too, is that sometimes one study ends before another study begins. And you may have staff that have a couple of years of experience in running clinical trials, but how are you going to keep them on board if there's a gap between funding? We also recognize that people have lives and that they want to move on to other things. We also have learned the hard way that we lose staff during clinical trials. And that, I think, is one of the most important concepts, most important issues that we can address. And you start to address it before it happens, not after. We have had changes in PIs on clinical trials, sometimes 2 or 3 PIs. We've lost research staff, research assistants. We've lost nurses, nurse practitioners. We've had to keep going, and I think to some degree, the way you do that is redundancy number one, and that is I always think it's important to have cross-training of staff. You have to have someone who knows, you have to have two people who know how to do the same job. One may take the lead on that, but if somebody leaves, you have somebody who can tide you over. These are not simple positions to fill. There's a lot of prerequisites. Oftentimes, we're not able to hire people with lengthy vitae, including a lot of research experience. So, in keeping my eye on the clock, I just want to emphasize that I'm sure that everyone has run into this. For us, even though we've been able to manage it, we know how to handle it now. Losing key staff is a very, very big deal, I think. Next slide, Tracy.
Thank you, Al.
Uh-huh.
Thank you. We're going to move this along. I want to hand this over to Greg, who's going to give us some critical aspects to consider when we're measuring performance. Greg, if you could speak a bit to that. Greg?
It works better with the mute button off.
Yeah, I think
Sorry about that.
Okay, great.
You guys should have heard what I was saying. It was great. All right. So, yeah, just running short on time, I want to briefly go through. So we do have the trial monitoring reports, and we've mentioned, all of us have mentioned that and the importance of those. What work shifts over the course of the study, so using those reports to monitor current progress and to be proactive in solving problems is obviously key. We all want green lights. Next slide. We all want green lights on the monitoring reports. So for enrollment, treatment exposure, audit results, primary outcomes, follow-ups, those are all things I mentioned sort of in my chain analogy earlier, that without all of these, we cannot have success. Next slide. The reports are updated. The performance aspects of the reports are updated daily, and they're just really a critical tool. So I think it's good to make sure sites have access to those reports. They can be gotten at the CTN DSC2.com website, and with an ID and a passcode, site went and look at those on a daily or whatever is a meaningful time to look at them. I think that's a very valuable experience. We get a lot of pleasure and angst out of looking at those. I get back to the idea of environment as well. Our environment is not one of wanting to blame, either with QA reports where we might find things that we could be doing better, or in performance monitoring, but to develop a atmosphere of excellence and being good at spotting potential problems or areas for improvement, and looking at the trial unfolding as a continuing opportunity to learn and grow and do better. So I think we'll move it along now.
Okay,
Tracy?
great. Also, I wanted to give the audience an opportunity to hear more about the success factors, and I know Dorothy was going to give us some discussion on the success factors at closeout.
Okay. At closeout, to have a successful trial, you've had to have had strong recruitment, high treatment exposure, high follow-up rates, and then timely response to data and other queries. Again, this is all related to everything that we've talked about in the trial progress report. The most important thing for every single trial that we do is the availability of the primary outcome. If we don't have that, then we've lost everything. So it really, really is important in order to have a successful trial conclusion is that you do have the availability of the primary outcome, because that's the only way that we can determine whether or not the trial has been effective. One of the other important things that I just wanted to briefly touch on is providing feedback to the research and CTP staff on the outcome of the clinical trial. What did we learn? This is really important to do because I think that, the RAs come in every day, they do the assessments, they do whatever, they do their tasks, but they don't, what's the big picture? What does all this mean? So I think that once that you have completed the trial and you have some feedback about whether or not the research was effective. I mean, we have the lead team call that we always have at the end of the trial when the primary outcome paper has been finished that goes over all the study findings. And I think that's really important to convey to the research staff because it makes them see the impact of their effort, that what they did was truly, truly important, and that they made a major contribution to the trial, and it allows them to see the big picture of everything that they've done and what the impact of their efforts have been. So I think that that's one of the biggest things you can do to motivate your staff and to keep people interested in working on these clinical trials is to give them feedback on the outcome of the trial so that they can see the impact that they've had.
And Dorothy, I think that's an excellent note for us to end on. And I'll turn it over to Tracy to do the last minute.
Oh, great. Well, thank you all for, providing such wonderful information. There is one note that I would like to give Ed Weiss. He provided a good comment on recruitment, which is such a critical aspect of having success in trial performance, where he mentioned that there is a new emphasis on primary care and patient-centered home care. And in terms of recruiting participants provides a different complexity. The results of the recent studies that we're doing have eligibility criteria associated with hospital inpatients with the status for SBRT using the patient navigator implementation or medication-assisted trials in conjunction with inpatient detox. And I know a number of people on the line may, in fact, be involved in a trial with some eligibility criteria associated with this. So I wanted to also note that, and you can't get it from the general recruitment mechanisms, and so that's basically what Ed was trying to contribute. But I'd also like to open up the lines for others to make comments to that other participants may, in fact, get benefit from. So, operator, could you open the line?
Thank you. We will now begin the next question and answer session. As a reminder, if you have a question, please press star, then 1 on your touch-tone phone. If you wish to ask a question on the web portion, you can ask using the Q&A tab on the top of your screen. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Standing by.
Okay. So I'll go ahead and wrap it up. So thank you, everyone, for participating. Again, please go to the DSC2's website, to the trial progress report, and the investigator toolbox to find some of the tools that were discussed here. And the next time we'll have in July 17th, we're having a webinar on developing medication-assisted trials. So it's a good follow-up to this discussion. There will be a survey to go out to all of you about this presentation, so I would love to hear from you. Dorothy, Al, and Greg, thank you so much. This was a very engaging discussion, and we'd like to hear more. Thank you, everyone, for participating.
Thank you, everyone.
All right, that will end our session. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.